2D measurement of the left ventricular outflow tract. The LV outflow tract diameter is measured from a zoomed view of the LV outflow tract and the aortic valve, recorded from the parasternal long axis view. We can see that this image has been well optimized. We have used the highest possible transducer frequency, and we have positioned the focus around the center of the LV outflow tract. This ensures that we have the highest possible spatial resolution, which improves measurement accuracy. In addition, we can see that a 3-beat loop has been acquired. This allows for repeat measurements and averaging offline if required. The LV outflow tract is measured in mid-systole at maximal aortic cusp opening. So we will scroll through to acquire a mid-systolic frame, which is going to be around the upstroke of the T wave of the ECG. But what we are really focusing on is the cuspal insertion points of the aortic valve to identify when they maximally are opened. So I'm going to choose this frame here, where we can see good cuspal insertion into the anterior septum and where we can see the posterior cusp inserting into the anterior mitral leaflet. Our measurements of the LV outflow tract diameter are going to be made using the inner edge to inner edge technique at the blood tissue interface. So by placing the anterior caliper where the cusp inserts into the interventricular septum, around about this point here, and the posterior caliper is going to be placed where the cusp inserts into the anterior mitral valve leaflet. A good way to identify this point is to look at the anterior mitral leaflet and follow it backwards to where this cusp inserts, around this position here, ensuring the measurement is made parallel with the aortic annulus and perpendicular to the aorta. An alternative method for measuring the LV outflow tract diameter is to measure 5 mm from the annulus. So we would place the anterior caliper around this point here and the posterior caliper placed around this point here, again ensuring we are aligned parallel with the aortic annulus. We can appreciate these measurements are essentially the same, and this is because in theory the LV outflow tract is cylindrical in shape. The method I prefer is Technique 1, as you can see good anatomical landmarks which assist us in correctly placing our calipers. Method 2 can prove challenging, especially in patients with a mitral valve replacement. Also remember, when measuring the LV outflow tract, we need to average this over 2 consecutive cardiac cycles. If measurements vary by 2 mm or more, repeat until a consistent value can be reproduced. After demonstrating to the students, I would ask if they had any questions. I would answer these questions if they had any. I would then use this table to summarize the content, with the answers hidden until attempted by the students. I would ask questions such as, what is the echo view we are using to measure the LV outflow tract diameter? How are we determining the mid-systolic frame? Are we using the leading edge to leading edge technique or the inner edge to inner edge technique? And how many LVOT diameter measurements should we be performing? If they answered 2, I would say that is correct. But remember, we should be performing this measurement on 2 consecutive beats, not just any 2 beats. I would also reiterate some tips, such as if the measurements vary by 2 mm or more, repeat until a consistent value can be reproduced. Also, reference values are available for the LV outflow tract diameter measurement. As a guide, the LV outflow tract diameter is around 2.1 cm, but varies depending on gender and body size. Always try to think about what you are measuring, question yourself if it is normal or abnormal, and try and piece the puzzle together as you are scanning your patients.